Let's talk a little policy. And I think we can do this today by starting to talk about what we know and how we know it. And so that's kind of our going to be our theme for the day. What do we know, and how exactly do we know it? So I want to frame how we're going to approach policy. I want you to always begin every discussion we have and every class we have by asking some simple questions. What do you know? And so you have all of the stuff that you've read in the mini readings that I give you, and you have all the stuff that you read that other people share, and you probably have everything you read on social media, everything you saw on the news, some of which is good sources and bad sources. But you have lots of sources of information. So part of what you have to do is learn to be a connoisseur of information and learn to identify what is actually true and accurate. So what do I know? Is this a good source or a bad source? So we even know with our peer-reviewed journals, there are some really great ones and there are some pretty bad ones. And then how do we know it? So you always have to weigh how you know different things. Do you know it because you saw it in a peer-reviewed journal? That would probably be a fairly high level of evidence. Do you know it because you see it in your practice? And then that's the question, is my perception changing the way I perceive things? So think about it this way. I go in, and if you read any of the discussion boards, which in the face-to-face class you don't have to, but a lot of people were talking about EMTALA and uh, basically that people come into the emergency room and you're required to treat them. Well, what you're required to do is triage them and make sure they don't have a life-threatening condition. But it doesn't mean you necessarily have to treat if they don't have a life-threatening condition. However, it was interesting because the perception of the people working in the ER was that everyone uses the ER inappropriately, and they come in when they could have gone to their primary care physician or nurse practitioner, or they could have gone to a clinic, or maybe even gone to urgent care. But they instead used the emergency room. And one of the things you have to tell yourself and ask yourself, is my perception being influenced by the fact that these are the people I see? The people that come in once because they broke their arm and they really do need to be seen in the ER, or they came in because they had chest pain and maybe the chest pain wasn't a heart attack, maybe it was reflux and they'd never had it before and they thought that it was a heart attack, or it could have been anxiety, and they may never come back again. But you don't see them. You see the person that comes and uses it as a primary care provider. And all of a sudden, your mindset is everybody does this because that's what you see. That's what you see all the time. So when I was in grad school, they had us do one of these personality things. You guys have all done some kind of personality test, right? And one of the things it asked you was, do you believe most people are lying to you? And it was really funny because that is testing something about you, not a good thing. And I'm like, now do I tell the truth and say, yes, I think most people are lying to me because I know what this means, or not? But the problem is I had just come off of a stint of working for like 4 years in a prison system. Most people really were lying to me. And I knew that in the general public that wouldn't be the case, but the people that I had been working with for a long period of time frequently lied to me when the truth would have done as good. I'm like, why are you telling me this big story? All you had to do is say, I really need an aspirin, I have a headache. I don't need to have some story made up for you to get that. But it was interesting. So remember that how you know it matters. Sometimes the data doesn't back up what we see in practice because we're not seeing the people we don't see. Always think about, is it politically feasible? So really, I would like nobody in the world to own a gun. I think that if we redid the Constitution, we would be better off without a Second Amendment. But guess what? That is not politically feasible, and it's not going to happen. And if you think you're going to reduce the number of guns in the country by trying to get rid of the Second Amendment, all you're going to have is people hate you, people that won't listen to you, and you're going to accomplish nothing because it isn't going to happen. So you have to find something that is politically feasible. I don't know what that is right now in our current political climate, but I'm sure there's something. You have to know if it's going to be effective, if it's going to be efficient. Is it going to reduce cost? Some things you want to do, you can do, but the truth is you're going to spend a lot of money for very little benefit, and so people won't do those. Is it equitable? Does it increase access? Does it increase quality? Does it increase health outcomes? So, all these pharmaceutical companies are forever coming up with new drugs, right? And they come up with a new drug when there's an old drug that will do the same thing. That's just as effective, except that its patent has worn off, and so they can't charge you a small fortune for it now. So they come up with a new drug. The question is, if it's no more effective, why would you use the new drug? Maybe if it had fewer side effects. But if it's the same side effects, and like lots of medications, it's the same side effects, it's equally beneficial, why would you pay more? We have to ask ourselves these same questions in policy. But what I want to make sure that we don't do is get so wound up in practice that we forget that the class is about policy. And a lot of times, we tend to go back with what we're comfortable talking about. So we are all comfortable telling the nightmare story in the ER because we can tell you our horror nursing stories all day long. Now, how do you relate that back to the policy? So otherwise, we will do what we find fun, and I can talk your story, whatever it is, right? We all can play that game. But we want to talk about policy. So for us, what do we know about the healthcare system? So let's talk a little bit about history because it helps to know our history of how we got where we are. And I am not going to give you 200 and some odd years of history, but I'm going to give you some highlights to kind of frame the conversation for the rest of the afternoon. So it's only been about the last 60 years that there's been a large role in the government in our payment system. Before that, pretty much everything was charity or private pay. There really wasn't a massive insurance system in the U.S., and there wasn't a massive role for the federal government. Most of the early hospitals were to care for the poor and those without families to provide care for them. It's a place you went as a place of last resort. People didn't want to be in the hospital because they got sicker. They got what we now call hospital-acquired infections, except then they didn't have antibiotics, and so they died from those hospital-acquired infections. And in reality today, back then you would go and you would stay for weeks, and now we know you want them out the door as fast as you can. The longer they're there, the bigger the chance something bad will happen, like, somebody will come in because I can't possibly not come visit grandma, even though I clearly have the flu, and then give it to everybody, right? So we all have those stories too. Hospitals develop for various reasons, but among them are concern about the sick immigrants. Yeah, there was a time in our country, oh wait, that's kind of today too, isn't it? There was a time when it was worse, and we thought that immigrants carried disease. And so much of this is going to sound like, oh, wow. Yes. But at any rate, there was a time when people were concerned that immigrants carried disease and that we wanted hospitals and places that sick immigrants could go for their health. Now, part of it was actually altruistic. A lot of the immigrants came in, they did not have families. And so there were no families to care for them at home, and so they wanted a place that would provide the care. There was a belief that there was prejudice in many of the Protestant hospitals against Catholics and Jews. So the Catholics and the Jews built their own hospitals. which caused a proliferation of hospitals. And then industries decided to build their own hospitals because they would have hospitals, they wouldn't want hospitals where they were. So as they built the railroad across the country, there was a need to have hospitals that were nearby. Textile companies built hospitals, big mining companies built hospitals, and so we saw industry seeing a need when they took these workers where they were now not next to their families, and they would also need health care. But let's talk about Florence, our favorite nurse, right? And it's really funny because I've read policy for a long time, and I'm a true blue nurse. I buy into all the Florence Nightingale stuff. I own the book. I like to read it. I still read it from time to time. But I don't think this had ever quite occurred to me in this frame because this is a new book for me. I had not read this or used it before the semester, so it was new to me. But we know that war promotes medical advances, and it moved hospitals from places of last resort to a place that actually made people better. And if you doubt the role that war plays in what we do, before World War II, nurses couldn't take blood pressures. That was considered the role of the physician. It was the need for nurses to do more in times of war that got to the point that nurses took blood pressures. Nurses did the majority of the triage. Before that, that was not the role of a nurse. So it does change practice, but it also changes in our ingenuity and how to do things a different way to make lives better and to get people a better health outcome. The two big wars at the time were the Crimean War and, of course, the American Civil War. And at that time, right now when we have a war, we count the number of people that we lose. And as a country, we kind of get really upset over 4,000 deaths. We think that that's huge and unacceptable. And we look at the number of people that died in Vietnam now and we think, how did that happen? But if you look back to World War II, that was a big number. But if you go back to the Civil War, it was huge. And it was brutal in a way that it isn't now. Because if they went through a civilian area, yeah, it didn't matter. I mean, we didn't have the strategic try to avoid civilians we do now. So there were all of these horrible injuries. It was about this time that two things happened. One is Louis Pasteur came along and they came up with germ theory. So it was the first time we really understood the concepts of germs. And Florence Nightingale wrote notes on hospitals. And it was actually about how hospitals need to be run, how you manage the workforce, how you manage the lighting and the ventilation and the cleanliness, and it drastically dropped the mortality rate. And it was probably the biggest shift in mortality rates that had ever occurred. And as a result, hospitals grew and the safety in hospitals grew and your outcomes in hospitals changed. And that was not because of physicians. That was because of nurses. And nurses, before physicians, took seriously that you needed a standardized education. At this time, physicians also did not have a standardized education. There was no standard. Most of them learned from another physician. There was no requirement for licensure, and there weren't really big schools that trained them like there are now. So you have to say, what happened? Well, as a result of this, the number of hospitals grew. In 1873, we had 178 hospitals in the country. By 1920, we had 4,000. And by 2018, we had 5,534. Now, obviously, our population grew and it's significant changes, but the thing that really made the impact was hospitals became a place to get better. And a lot of that was due to not only changes in practice, but changes in policies. And I know this is probably a slide that's going to be a little hard to see, but it's in your book. Actually, this one's a link to an article, but these same things are in your book, except they're divided into multiple different tables for you. So this is a table I found that's all one table about summary of kind of key tipping points for individuals by year. So one of them was 1854 in Florence Nightingale, 1851 sanitary commissions. These are big tipping points that occurred in education and of nursing and healthcare professionals. And you notice it's not till 1910 that you really see there start to be this Flexner report, which was about medical schools and what they needed to do to adequately train physicians. We started seeing the pharmaceutical industry grow. Remember, prior to World War II, we didn't have antibiotics. So people got infections, little things that we consider now an automatic, you get over it, and people died from them. And we started changing it really about World War II was when the big changes started to occur and the way we looked at how we financed healthcare. And that was really important because you have to pay for everything that you do. So hospital growth basically stopped between the Great Depression and World War II. And for obvious reasons, most of them financial. We were clearly heading into war, and there were other things that were taking the nation's attention. So after this passage, Truman decided that he really wanted, for all practical purposes, a single-payer system. Truman wanted the Social Security Act to expand insurance to all Americans, but it was opposed by Congress. It was also opposed by the American Medical Association. And remember, even up to the Affordable Care Act, pretty much the major opposition to a single payer was the AMA. And it was all a financial decision, largely a financial decision with them, partially because they thought they would lose control over the care, and the care would then be dictated to them by whoever the insurance or the payer was. Now, there's some truth to that. There's absolutely no doubt that there's some truth to that. But you have to do the checks and balances on, is it better for everybody to have care that may be controlled because of resources, or is it better for only those that can afford to pay for it to have care, and everybody else can, have what's left over or what they can afford to get through charity care? And Truman believed really that everybody should have care. So the growth in the insurance also expanded the growth in hospitals. And we know that in 1970s, hospitals reached their peak. There were about 5,800. So we have fewer now than we had in 1970. And so by giving people insurance, it gave people money to pay for their care, money to pay, shoved money into the hospital system. It allowed hospitals to have adequate facilities, amazing technology, better qualified staff, to pay the staff adequately, to not have people that worked like crazy hours so that they were not providing good care. We even got to the point now that we say, yes, you can't have medical young residents work days on end without any sleep. That's not really safe. And all of these things changed where we were. And so medicine went from just this profession to this profession of privilege. They went from a point of becoming what really is a profession to the privileged profession. The AMA unified as a profession, and they did this because they stopped saying, you don't count, and you don't count because you're not the right kind of physician. And they started saying, yes, you're all physicians. And when they did that, their numbers grew hugely. So Paul Starr describes it as professional sovereignty. which you can read more about in his book. And he said it's the capacity of a profession to extend and transform its authority into social change, economic power, and political influence. And I would say that none of us doubt, if we compare ourselves as nurses to physicians, that they have a whole lot more of all of that than we do. And what happened differently? What did they do that made that difference? We will discuss that throughout the semester, and we'll use it as a recurring example because it's something we all know well. So it's always good in policy classes to use things as an example that you know fairly well, because then you can relate practice to policy and hopefully make it easier to understand than how you would apply it to other things. Thus, they had an unequal share of both authority and economic benefit. There remained one problem, and that was their inadequate medical education. So it, at that point in time, was not standardized. So we went from evidence to improvements of hospitals. So while medicine accumulated power and authority, nursing made the changes in hospitals that resulted in the difference. And that's what I was telling you about, the changes that Florence Nightingale actually made, so that hospitals became these places of healing. While medicine struggled to standardize their education, Florence Nightingale was standardizing nursing education, and the results could be measured in changes in patient outcomes. And we still do that. It's why some of you are getting PhDs and some of you are getting DNPs. People are getting PhDs. They want to do the research. They want to identify the problems. They want to figure out how we can change outcomes. Nurse practitioners frequently are studying evidence-based practice. How do you take what their research and how do you put it into practice at the bedside or in a clinic? And how do you actually make it change those lives? So one of the things I will tell you in a policy class, and you will hear me say it repeatedly, is all the research you do in the world means nothing if you can't share it. It means nothing if you did the research, but you don't work to get the policy changed to change the practice. It's just research. So somehow you have to get it from where you did the research, and you have to get the policy change, and you have to get it in the practice. And we will work on how you successfully do that. Nightingale insisted on a system where only nurses train nurses. Why do you think she wanted to do that?
Well, in the reading it said she was afraid that if nurses did, like if physicians did it, then they would just totally kind of bulldoze any of the ideas or initiative taken by the nurses.
Yep, true.
I think she's afraid that the nursing profession will be dependent on the physicians, and we will and that at that time it's kind of there is some like sexual discrimination.
Correct. Physicians were, while early in our history of having physicians, there were a fair number of women. Over time, the men kind of shoved out the women, and we went for this long period where it was a very male-dominated profession. This was the first year. This year, more women were admitted to medical school than men. This year. So I think that's an amazing step forward for women and for the profession, for the medical profession. But nursing had been and remains predominantly female, and the belief was that the male dominance over the women would kind of just basically turn them into handmaids for all practical purposes, and that we would lose control over our profession and our professional identity. It was interesting. I interviewed for a job once at a school way down south, and I knew early in the interview that I would never, ever, ever be willing to work there. And the reason was because two people told me the same thing. One was the president of the university, and one was this man that was on their board that they had me talk to, who I can't remember what his actual role was. But their belief was that they should overtrain the number of nurses they needed. So make this oversupply of them, knowing that there was no need for that many nurses in that small area, because they wanted to drive down the salaries of the nurses in the hospital to make it cheaper for the hospitals so the hospitals were more profitable. That was not going to work for me. But largely because if you produce an oversupply of people, the other thing you're doing is you're having people that don't have adequate training, they don't have adequate skills. I mean, you drive down morale, there's all kinds of reasons that you would not do that. But I thought that that was just a horrible thing to suggest doing. But it was a very male physician-dominated environment. And that's exactly the type of thing that Florence Nightingale was worried about, which is why in any state you have to be a nurse to teach nursing clinical courses. You must be. You must have that RN licensure. So you can also be a physician, but you must have that RN too. So it was a good thing, and it served a purpose. And then, of course, there was insurance. So that was one of the next big things that came about in our country. The AMA consistently opposed early attempts to provide insurance to all. They believed, A, that it was going to undermine their authority to care for patients, and B, that it would bring their lucrative fee-for-service model to an end. We all now know that fee-for-service is a really expensive model. How did they do it politically? They did three things. See if this sounds familiar today. They declared government financing of health care as radical socialism. They labeled government bureaucrats as having predatory tendencies. And they kind of insisted the doctor-patient relationship was sacrosanct. So, two of those, I would say, are still really problematic today. Now, I cannot say I disagree with the doctor-patient relationship needs to be kind of sacrosanct. I don't think anybody should intervene with that. I really do think if you want good quality care, the provider and the patient should have a very confidential private relationship that people can't mess with. I don't think that I should be able to tell other people how to make their decisions, because I'm a big believer in self-determination as a principle. Now, is there evidence that that makes for better outcomes? Not to my knowledge. It's something I believe is a moral principle, but it's not something that I know that there's knowledge of. So maybe we'll find some this semester. Because when you're making a policy argument, you can't say because I prefer it. Although they did very well exactly that, but they did it by sowing kind of this conspiracy theory. Radical socialism, predatory tendencies. The government's out to get you, essentially. So, sadly, that still works on people today. So how did the federal government finally get itself into the medical care of our nation? Well, it did it in several ways. First of all, it created marine hospitals, which were part of what became the United States Public Health Service. And the marine hospitals were set up for merchant marines, so that all around the coast there were these hospitals that cared for merchant marines, these merchant sailors that our commerce was dependent on. Nobody wants to mess with the commerce. If we mess with the commerce, what's it mess with? Money, 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 money. It's all about the money. Then they did the National Quarantine Act, which is, of course, to give the government the authority to quarantine people if need be. Now, we still have a Quarantine Act, and it's rarely used because it's believed that if you quarantine people, that quarantine will cause this mass panic. So if you ever want to talk to me about quarantine and disasters, that's another whole conversation. Then they created war risk insurance, which provided medical benefits to veterans. And of course, we still have forms of that today. And we have an entire Veterans Administration to provide medical care to veterans. We have TRICARE that just provides insurance to military members and their families. If they retire, it provides it to them for the rest of their life. Then public safety regulations. But the one I want us to talk about and think about today and use as an example of why some policy is important is the Tower Act. And there are many policies that I think are hugely important and change the way we think of healthcare, the way we do it, and impacted health outcomes across the country. But I just think this one's important for multiple reasons, and especially with us as nurses. So the Tower Act of 1921 focused on maternal child care and came as a result of the suffrage movement. Everybody knows what the suffrage movement is, right? It's what gave the women the right to vote. And so in many ways, when you see people out marching in the streets today and you see some occasional violence, it was nothing compared to what these women faced that marched for the right to vote. They were frequently arrested. They were imprisoned not for a day or two because social media came to their rescue and people camped outside the jails. They were imprisoned for months. They were beaten in prison. They were beaten in the streets. They were threatened by people. People showed up with counter-protests that were frequently quite violent. So these were amazing women that made sure that we all had the right to vote. And to get this passed, people really wanted to link this piece with the suffrage movement because they thought if they could get these women who were very active on their side, that this would move the Tower Act forward. And for a brief period, Congress funded federalization of care of women and children over the opposition of the AMA. So the American Medical Association opposed this. Why did they oppose it? They opposed it because, woman care, child care was lucrative. They made money. And if you did this, it took that away from them. So, unfortunately, it didn't last long. In 1927, it was repealed despite being very popular in rural areas and especially in these agrarian societies or these agrarian groups. So there were these groups of people that wanted to kind of live on the land and make their own way. And they did this because they thought there was a better way of life. And it was the time of Dorothy Day and the movement of the Catholic worker houses where people would go out and they would come together as a community and they would buy this land in rural areas and they would live minimally, but on the land. And by minimally, I mean in a way that probably none of us could imagine. Frequently, they didn't have electricity. They didn't always have running water. There would be multiple families that would live there together. And they faced lots of struggles, but they pulled their resources to make a better life. A lot of these people had been people that were poor in the inner cities, and they came out of the cities to try to do this. So the bill had its flaws. It largely focused on white infant mortality, and most of the money, and the money was minimal. It was like many things. It was never fully funded. But the money was minimal, but it largely focused on rural white women and pretty much ignored minorities, the inner city, and immigrants. So, and it meant American-born rural white women. So it had some significant issues. It was one of the early attempts to use empirical science to influence the political debate and decision-making. The empirical evidence came from female social scientist. So it was a bill about helping women. It used for the first time in the policy debate empirical evidence, and the empirical evidence came from female scientists. This was a big deal in 1921. I mean, it really was very radical at that time. The methods they used became known as preventive science. It was the foundation of the role of the government in public health and health care for the poor and the underserved, and it was really the first time that the government put money behind prevention, and that we looked at preventing disease rather than treating it after somebody already had it. So what they really wanted to do was prevent. Good public health policy lost to political self-interest, though. And it all became about profits for physicians and not about what was good for the public health. And we still see this today, less with physicians. Who's the big culprit of this today?
Hospital administration.
Who else? There's a bigger one than that.
Lobbyists.
Huh?
Lobbyists.
Think medical, though.
Insurance companies.
Who makes big money on what they sell you and you have to have it? Pharmaceuticals.
You have to save money in.
Right. So the U.S. pays a huge amount more for pharmaceuticals than any other country. Why? And so something else to think about, not solved now. But so while you don't see this as much today in medicine, you really see it largely in the pharmaceutical industry. So here's some references for you to look at and to think about. You can dig a little deeper, but now I want us to have a discussion about how we take the next steps and how we apply this to our practice. And starting tomorrow, I will put up a Twitter chat that we can use to discuss, and this is one of the ones I said I'll have throughout the semester. And we will discuss the role of significant healthcare legislation in changing our system. So just because I thought this was an amazing piece of legislation that make a big difference, there may be something to you that you think had an even bigger impact. And we're going to talk about it a little bit now, and then it will be the focus of our Twitter chat.